Good day. I'm Dr. Kate Leiritana, and I have the pleasure of sharing with you HIV care during the COVID-19 pandemic in the Philippines from an NGO perspective. I'm the Medical Director of Sustained Health Initiatives of the Philippines, or SHIP, a nonprofit organization engaged in capacity building of HIV providers and producing free and low-cost HIV clinics in the country. In the next 20 minutes or so, I will endeavor to describe the effect of the COVID-19 pandemic on the national HIV services and to describe the innovations made to continue HIV healthcare delivery during the pandemic and to discuss the future of HIV service delivery in the Philippines using a reimagined blueprint. First of all, I'd like to introduce you to the structure of the HIV program in the country. The Department of Health provides policies, resources, technical support, and capacitates providers in the more than 160 treatment facilities in the country, which are located in tertiary hospitals, primary care clinics, and in community-run centers, all of which provide services in varying capacities. There are LGU-run facilities as well, which also benefit from city or municipality HIV policies and resources. The Philippine HIV community also benefits from the support of various partners and stakeholders, which are international development organizations that invest in the program through funding, capacity building, technical support, among others. The HIV law, or Republic Act 11166, mandates that the state should ensure that evidence-based, rights-based policies and programs are in place to ensure meaningful engagement of people living with HIV and the at-risk community. Having a law that supports and protects PLHIV is essential, beneficial, and is something we are grateful for. The services provided by the HIV program can be visualized through the HIV care cascade or the HIV care continuum. This is a public health model that shows the journey that a patient who undergoes HIV testing goes through. It covers both the path of someone who tests positive for HIV and someone who tests negative. The goal is to achieve a community with a low HIV prevalence. And because of advances in medicine, both the person living with HIV and the HIV negative individual contribute to this outcome. For the positive path, this takes the patient from diagnosis to medication and treatment retention to achieving and maintaining viral suppression. In 2016, it was shown that people given combination prevention packages composed of HIV information, access to condoms, and testing for HIV in the past 12 months were 6 times more likely to use a condom than those who did not receive any of the components. In 2020, during the pandemic, HIV testing decreased by 61%. Condom use also saw a decline, although not very significant, except for the NCR region, which only saw 17% condom use among at-risk population. In general, the prevention strategy decreased from 26 to 17%. This is quite lamentable because the risk, despite the lockdown, was ongoing. The proportion of at-risk population engaging in anal sex was sustained, as well as the number of partners and average number of months that people engaged in anal sex. This means that the risk was still ongoing. However, it was noted that the prevalence of cruising or going to a specific place to look for sexual partners decreased, and more men who have sex with men and transgender women shifted from having multiple sex partners to having regular sex partners. The number of HIV cases documented in 2020 decreased across all age groups, and this is likely because of a decreased access to testing. Thankfully, though, we have seen recovery in testing rates in 2021, and we are now seeing rates similar to pre-pandemic times. So COVID-19 derailed HIV progress. I think this is a universal finding. It's sad because the gains of U equals U or undetectable equals untransmittable, or the statement saying a person living with HIV who has an undetectable viral load does not transmit the virus to their partners, and the existence of a working pre-exposure prophylaxis, which could have led us to decreased HIV transmission, were countered by a lack of access to these medications. And therefore, the treatment gap in the Philippines widened even still. We now have 67,000 PLHIVs in the country who should be on medication who aren't not. Now, here are some things that happened during the pandemic. I will be sharing limitations as well as innovations and solutions. Because of the high rates of hospitalization, tertiary hospitals became COVID facilities and had to divert most resources to address this emergent need. HIV clinics based in tertiary hospitals, which occupied a third of the facilities in the program, needed to close or limit their services. This led primary clinics to accept transient patients. The situation called for all hands on deck, and because we were all under one program, communication was quick. We were mandated to provide services to any patient who needed medication, regardless of wherever they were enrolled. And this included foreign patients stranded in the Philippines. We remained open despite the harsh lockdowns at the beginning. This program led to efforts from clinics and community-based organizations to think outside the box, to innovate. We were also glad to receive support from the partners, DOH, and local government units, as well as community and various donors. Adaptive measures were the following. Clinic staff continued providing services in their facility or at alternate venues and even through mobile means. Personal visits shifted to online consultations, whether via video calls, phone calls, chatting, and even texting. If patients could not come to the clinic, the medications were eventually shipped to them. A crowd-funded project initiated by the community called Our Bayanihan was launched in partnership with Angkas. So free medication delivery was offered to those patients who could not afford shipping. And in many clinics, this was eventually picked up by the partners and PhilHealth and came as no cost to neither the patient nor the facility. HIV information dissemination, awareness programs, and outreach continued as well and found a great home in social media via vlogs, live webinars, and community programs. HIV outreach continued even through dating apps, and HIV testing was brought to where the client was. Community-based organizations' presence were felt not only in the CBO-led centers, clinics, and hospitals that they volunteer in, but also direct PLHIV assistance was provided. Community-based organizations and non-profit organizations addressed the financial concerns of PLHIV through various charitable endeavors. Prevention activities were also continued by providing commodities such as condoms, lubes, and even COVID PPEs. Support to the facilities and community groups were provided by the HIV stakeholders and partners through funding, technical support, capacity building, and continuing professional development of providers, as well as health literacy of PLHIV and at-risk populations. The medication delivery was eventually supported by UNAIDS as well. The HIV program had distinctive leadership in the DOH NASPCP program, who created policies for guidance and communicated this to all regions to reach us through the various centers for health development. And these are the policies that we referenced throughout the 2 years to guide us. We have guidelines on the continuous provision of essential health services during the COVID pandemic. And these are the policies that we referenced throughout the past 2 years. Irene Kilantang, a PhD student then of Brown University, envisioned a future of HIV service delivery based on the blueprint of the pandemic experience. In a way, the pandemic was a blessing because we were forced to provide differentiated service delivery ASAP, which is a client-centered mechanism. First, why don't we bring the services online? From counseling, consults, referrals, requesting for medications. This should be a viable option beyond the pandemic. Improvement on privacy and technicalities may be worked on until then. Second, improvement of the antiretroviral therapy supply chain. Stockouts, transportation delays have caused patients to miss out on life-saving medications. Courier services were a godsend to patients, but warehouses should be located in district and provincial levels for better access. Funding for couriers has been provided by the partners and PhilHealth, which was a problem circumvented. And third, enabling patients to secure their medication from any of the more than 160 treatment facilities. This can be a game changer for access. Of course, it will necessitate a centralized database, some form of feedback mechanism, and organization. But the ease of access and resulting quality of life provided to the client Irene Kilantang, a PhD student then of Brown University, envisioned a future of HIV service delivery based on the blueprint of our pandemic experience. In a way, the pandemic was a blessing because we were forced to provide differentiated service delivery, or DSD, ASAP, which is a client-centered mechanism. First, why don't we bring the services online? From counseling to consultations, referrals, and requests for medications. This should be a viable option beyond the pandemic. We can improve on privacy and technical ease later on. Sorry. Okay. Irene Kilantang, a PhD student then of Brown University, envisioned a future of HIV service delivery based on the blueprint of the pandemic experience. In a way, the pandemic was a blessing because we were forced to provide differentiated service delivery ASAP, a client-centered mechanism. First, why don't we bring the services online? From counseling, consults, referrals, requests for lab or medications. This should be a viable option beyond the pandemic. Improvement on privacy and technical ease are things we can work on. Second, improvement of the ART supply chain. Stockouts, transportation delays have caused patients to miss out on life-saving medications. Courier services were a godsend to patients, but warehouses should be located in district and provincial levels for better access. Funding for couriers has been provided by the funders and PhilHealth, which was a problem circumvented. And third, enabling patients to secure their medication from any of the more than 160 treatment facilities will be a game changer for access. Of course, it will necessitate a centralized database, some form of feedback mechanism, and organization. But the ease of access and the resulting improvement in quality of life provided to the patient will be invaluable and is something to definitely look forward to. With lessons learned from the pandemic and a future of possibly returning to near normal looming ahead, it is important not to fall back into old ways. What's more, changes are definitely in the horizon for the HIV program, especially with universal healthcare. Under UHC, HIV is considered as a population-based service. The DOH will oversee financing, capacity building, and capital investments to complement government resources. However, it is expected that HIV testing and linkage to care in more specialized treatment facilities will be a service provided in the primary level. Province-wide or city-wide health systems shall manage all the resources intended for health services to finance population-based and individual-based health services, health operating costs, capital investments, and remuneration of health workers, as well as incentives for health workers. This is to be governed by the Special Health Fund guidelines provided by the Department of Health, Department of Budget and Management, and the LGUs. While the National Health Human Resource Master Plan will provide policies and strategies for personal concerns. With lessons learned from the pandemic and the future of possibly returning to near normal looming ahead, with lessons learned from the pandemic and the future of possibly learning to live with COVID looming ahead, it is important to not fall back in the old ways. With lessons learned from the pandemic and the future of possibly returning to near normal, or at least knowing how to live with COVID looming ahead, it's important we not fall back into old ways. What's more, changes are definitely in the horizon for the HIV program, especially with universal healthcare. Under UHC, HIV is considered as a population-based service, which means as the DOH is overseeing the financing, capacity building, and capital investment to complement government resources, it is expected that HIV testing and linkage to care that is currently found in more specialized treatment facilities will now be a service provided in primary healthcare units. The move to UHC is something that will benefit the country for sure, but the transition will be difficult as the HIV program has been DOH-centric. LGUs will need to be fully equipped to be politically and fiscally responsible for the treatment facilities and PLHIVs under their jurisdiction. The lessons learned from HIV helped us navigate the COVID pandemic. Hopefully, these lessons won't be forgotten. Thank you for your kind attention. The move to UHC is something that will benefit the country for sure, but the transition will be difficult as the HIV program has been DOH-centric. LGUs will need to be fully equipped to be politically and fiscally responsible for the treatment facilities and the people living with HIV under their jurisdiction. The lessons learned from the HIV Lessons learned from HIV help us navigate the COVID pandemic. Hopefully, the lessons learned won't be forgotten. Lessons learned from HIV helped us navigate the COVID pandemic. Hopefully, these lessons won't be forgotten as we navigate more challenges ahead of us. Thank you for your kind attention.